And again, as soon as I get this exam review done, I will be sending it out to your professors so that we can get it posted on your announcements, okay? Also, those coming a little bit later, I will be sending out a dosage calc. It's 10 questions. Go over it, review it, if you can understand how to make dosages, how to figure out how much you're going to give, there's a couple tricky ones in there, some conversions in there. You'll have them. And that's what you're focusing on this exam, okay? So that being said, let's get going. Concepts, look at that. Let's go to from the beginning. So it is weeks only 4 and 5, but it's a lot of information, isn't it? It's chapters 21, 23, and 24. Now, I just went over and reviewed the exam again because, yeah, all our exams are different, but it's all the same concepts. If you're understanding, number one, definitions are definitions. Those you just have to know. I can't give you an easy way for that. But when we get into other stuff, I'll be explaining. So, conscious sedation, something we use a lot in the ER. You have a child with a bad break and you don't want to bring him to the OR. It's expensive. It's, stay in the hospital. Conscious sedation, they knock you out, but you don't need to be intubated. You're still able to breathe, but you don't remember a thing. That's why it's called conscious sedation. And these children have no clue. I always tell the boys, well, think that you're out playing basketball, or the girls, you're sitting at a beach, and they wake up saying, yeah, that's where I was. So it's conscious sedation. You still have an airway. Now, a clinical pathway is a type of plan that we make for your whole care, your whole entire treatment. As in, if you have a certain condition, there's certain set of orders set that you're going to give these meds, do this, do that, and what treatments you're going to give. It's the same. It's the pathway that we follow. And that's as simple as that. An emancipated minor is somebody younger than 18 who has gotten the legal rights for themselves, which means they have a legal right to sign for their care. Remember, at 18, you're able to sign for, but emancipated minors could be 14, 15. So they can sign for themselves and their own children without mom and dad because they are on their own. Now, regression is a part of your separation anxiety, isn't it? Second stage. This is where children start to go backwards, as in they're not sucking their thumb, they start sucking their thumb. Or they didn't drink out of, they've been drinking a sippy cup and they want a bottle. Or they're potty trained and now they're not. That is regression. So you go backwards in your developmental stages. Now, meningitis and encephalitis are confusing, but the brain has a covering called the meninges. So, meningitis is an inflammation of the covering of the brain and the spinal cord. And that's caused by group B strep, guaranteed group B strep, okay? Encephalitis is the brain itself, an inflammation of it. Osteosarcoma is a really malignant bone tumor. See it a lot in the adolescents, and it's usually a femur bone where they have to take a whole leg off, the femur bone out. And then they try to reimplant the bottom of the bone, leg up in there to put a prosthesis. But osteo bone sarcoma tumor. Ray's syndrome is caused by taking aspirin, usually following a viral illness. So, any comment by any parent saying, okay, they have a fever, I'll be giving them aspirin to tolerate the fever, and you will correct them. No, you'll give them acetaminophen and ibuprofen after they're 6 months old, okay? Ibuprofen can't be added before that. Has to do with bleeding and the bleeding coagulopathies. So that's why ibuprofen after 6 months. Now, sepsis. It's an overwhelming, the whole body joins in an infection, okay? It can be bacterial, viral, fungal. What happens when you go into sepsis? Well, your body is in shock, right? And that's a low blood pressure. That's a high heart rate, loss of consciousness, and it can cause death if not treated. What do you do to treat it? Get the blood pressure up, treat the infection. Now, I know you're tired of listening to the theorists, but they are involved in this exam on how we look at children and how we treat the children. Remember always, children are treated on their developmental age, not their number. Remember, Down's children might be treated a 4-year-old more like a 2-year-old, depending on where they are developmentally. So, something to remember. So, we know Freud is all about psychosexual. Oral is about sucking and everything in their mouth, exploring the world. Anal, potty training. Phallic is all about boys like moms and girls like dads. It's just starting to understand differences like that. Latency, he says, is they like their friends to be same-sex peers. Then, of course, in puberty, they start exploring their genitals, right? So they start being attracted. Now, it doesn't have to be opposite. So that's one thing I don't think Freud thought about, but it's just, a partner. So again, Freud stages of morality, they explore the world in their mouth. They put their fingers in the mouth. Remember, the pacifier, put it in the mouth, it's good for pain control and it's good for soothing. They self-soothe with it. Anality is a toddler. Now, remember, toddlers are all about, after the potty training, whatever, toddlers are the one that are autonomous. They want to do things by themselves, and they don't really understand right and wrong quite yet. They just know they get punished for bad things. And these children just know, no, no, me, mine, mine, mine. Now, then we go into the preschool, phallic, and that is talking about aware of yourself, boys and girls and girls and boys. As what I said, the boys like moms and the girls like dads. And then latency, again, learning to work in groups, and usually those groups are same-sex peers. Now, cognitively, that's awareness, that's understanding environment, right? That's Piaget. And I think a lot of times we have nurses has to look at a child in their stage and know how to talk to them. All right. That's why Piaget, we talk about it a lot. Now, of course, 0 to 2, isn't it all about sense, feeling, mouth, moving, building things? It's about shaking that rattle the first time and hearing a noise and going, "Oh, I like it." It's all about touching things and feeling things. That's all about these younger children. What sort of toys would you give those kids? Think about that, right? Now, a little nice stuffy toy with all nice and soft, right? Now, 2 to 7-year-old. Now they're starting to be more abstract. They like to know. They're of course imaginative. But the thing Dan that some things might look different, but they're really not. And it goes also into the concrete operation with Piaget, as in one tall glass, one short glass that's fatter. You pour the liquid, it could be the same amount. They're starting to know that. Putting colors together, toys together, all my cars, all my trucks, or all my red shirts, my yellow shirts. This is concrete. Also, Piaget says with concrete, it's something you have seen, you touch, you're comfortable with. So, wouldn't it be good for concrete operational before they went to the hospital or before procedures that we talked to that child about what's going to happen? Because now it's concrete. They heard it, they asked questions. I know what's expected. That child's going to do a lot better. Now, formal operations, these are the adolescents, as I say, can fight their way out of a paper bag because they can pull out concepts and things and put them together and know what they have to do to get what they want or need. Okay? They can fight their way out of that paper bag. So again, sensor or motor, we're talking about exploring. That's that when you put things and hide things, that object permanence, they know they need to go looking for it. And as they're looking for it, they're moving. They're moving their muscles. They're trying to crawl to get there and they're seeing. Pre-operational, again, now is start talking about um, not logic yet. They only know what things are until they start putting them together, as in they're going to say these are all the red blocks, the yellows blocks, the green blocks. They're not into these are all squares and rectangles and triangles. They don't know quite that completely yet. And then again, everything, their toys, they have feelings, that animism, as in trees have leaves so that when it rains, the roots don't get wet, or it keeps them warm when it's cold, or, animism, making things, the stick into the broom, into a flying airplane, or the stick and a knife. I mean, this is all the animism that we do. Again, concrete operations, again, they have to see it to understand it. And remember, these children all feel that they got sick because they did something wrong. This is your preschooler and your school agers. I was mean, I was bad. And because of that, I broke my arm, I fell down, I have an appendix. They don't know. And then, of course, they're starting to question everything like, so why did my dog have to die? Or birds can, but they can, and then trying to figure out they don't have wings, right? And again, formal operations, they can figure things out. They don't have to see it first. So Erickson, the ones that always are around, it's always infant. Somebody goes when a baby cries, they're in trust if it happens all the time, most of the time. And that mistrust happens when there's maybe some sort of disconnect in the home environment. Maybe it's homelessness, maybe it is poverty, maybe it's drug abuse, whatever. Then it goes in, as I said, autonomy. Toddlers, remember, love to explore. Explore, explore. But mom and dad are saying, be careful, don't do that. No, let me get you down. And then stopping that will that or per se they want. They have this desire to do it. And then 3 to 5 is your preschoolers that they want to go, they want to help, but they can't do everything, and it's a guilty part of them. School age, probably infants and school age and adolescents are the ones that I've seen on HESIs and NCLEXs that they really focus on the most. Um, Autonomy is just knowing that the selfish, they want me, me, mine, and they want to do. But school age, it's their industry, it's their factory, it's the house they've built, and they do it well. And that gives them a sense of industry, okay? That sense of industry is doing something, that they do really, really well. And if they can't do it well, they feel a sense of inferiority. Can you do everything well? I can't. Does it make me feel inferior? Well, I'd like to be able to do it, but if I had to, I would figure it out, right? And that gets into the adolescent figuring it out. Remember, adolescents are all about their identity. Okay, you're working with children in a hospital. These children should be with other children their age, if they can, according to diagnosis, to make them know that they're not in this alone, feeling these things. It's that identity, not feeling good about themselves, maybe having a scar, after surgery, and they don't want to wear a bikini, right? And then it's the nurse say, well, let me teach you how to take care of that scar. These are creams and lotions and whatnot you can use when it's healed or whatever. And then these older ones we don't go into. So again, infants, we know it's the trust versus mistrust, and we know that trust builds healthy personalities and happy babies. Toddlers, again, they want to go and do things. Now, studying is hard. So always tell them, oh, you did a great job, when they do something well. And, don't let them be defeated when they can't. You say, okay, we'll try next time. Toddlers now are going to try to feed themselves, dress themselves, and they're going to be start to saying, I want to eat, I'm hungry, a cookie, a milk, a juice. They're starting to talk and express. Preschoolers, again, these are the ones that now need a little bit of responsibility. Setting the table with the paper plates, not the glasses, or plastic cups, not glasses, in that safety minded thing. Giving them stuff. You could, of course, give them a pet or a plant. Not every parent does that, but giving them, putting the clothes in the dirty basket, help me put it in the washer, doing laundry, things like that. They love it. They like that to be able to have those responsibilities. And again, they also feel guilty because they are not known if they're doing things right. So again, encouragement. School age, as I said, they love to do things well, but feel bad when they don't. So again, it's that encouragement. And then adolescence. We know that it's all about them feeling good, their body image, self-esteem, and trying to figure out who they're going to be, right, as they grow up. Remember always Maslow's hierarchy of needs. It starts out with your basic needs of life, right? You need to eat, you need shelter, you need clothing, you need somewhere to, you need your good sleep. And then it goes into safety, it goes into love, and on top, feeling good about yourself. And knowing that esteem could be playing sports, that could be like the school age, things they do well, right? Could be that preschooler who put the clothes in the dirty laundry before mommy even asked. And mom says, wow, great job. So that's the way Maslow should be used. Now, Kohlberg. Actually, I like Kohlberg and what he says. It's all about right and wrong and a punishment for each. And as they get older, now, really, your toddlers and your infants don't really know much. They don't even know how to avoid sometimes punishment. So when they get to preschooler, now it's reward and punishment. That's what it's called at that level. So again, they've done something bad, they're sick in the hospital, they're being punished. That's Kohlberg, okay? Of course, school-age children love to please people. They like to be the good girl, the good boy. And then going up into teens, it goes into understanding what's morally acceptable in life, as in, just the rules of life. You open doors for people, your politeness, not smoking in a place you're not supposed to. As simple as that. I mean, I'm not saying adolescents should, but rules of the such. So hospitalized child, you're the nurse in the hospital and they're being hospitalized. So when does discharge planning begin? And that's always the minute they walk on your unit. I
Yes.
I always, when I was admitting anyone, parents and children alike, I'd be talking to the kid in a really nice, friendly, playful attitude on their developmental level, low, not towering over them. And I would tell them what I was doing and why I was doing it. And that is what, from the beginning, just taking beginning vital signs that was doing planning for discharge. Parents staying at the bedside is absolutely important, especially your toddlers and your preschooler and your young school age. What about the child who's Downs, autistic? Absolutely. They want, that comfort, that sameness, I know who you are. Now, if you can't have a parent there because, life, parents have to work, they can't stay there. What can we do as nurses? Well, of course, incorporating those home habits, their routine. When do they eat? When do they dress? When do they shower? When do they nap? What types of foods? All of those will reduce the anxiety. But how about the sameness of the staff? And then working around that child and their routines. But routines are important, especially on your young kids, on your Down children, your autistic. Now, think about a low blood pressure. One of the things, and we don't think about this, if you're not getting enough blood to the brain, you're going to have an altered level of consciousness, aren't you? Because what does the brain need? It needs oxygen to function. So if your blood pressure is low, it's not pumping the blood with the oxygen to the head. So guess what? You're going to have an altered state of consciousness. They might not remember mommy went downstairs or mommy's in the bathroom or just simple things like that. I call it almost like an amnesia. So in the hospital, caring for children, some of the things that we can do, because parents are scared, parents are nervous. I was that young looking, like I was 14 still, and I had been a nurse for over 10 years by that time. I was a nurse at a very young age. And they look at me and like, how long you been a nurse? So they're like scared to allow their child to stay with me. So things that you can do. Reassure them. Let them know what's going on. Teach them. Get that sense of trust. Tell the parents if you don't know, you'll find out, right? With children, if something's gonna hurt, you need to tell them, be honest, but also say, I'll do everything possible so it won't hurt too much. Don't ever lie because they will never trust you again. Again, home habits important. Those objects, the blankie, that super binky, whatever that toy is, that pillow, the pajamas, whatever it is, try to keep that with that child because that helps. Soothing techniques and play. I think the one thing that I've always taught my students is I worked in pediatrics for 25 years and I went to work and I played every day. And I think it's why I love pediatrics so much because even in code situations, I'm a calm person and I'm still there playing with the child, holding their hands and making it less threatening. And it does work, okay? We know that play, like dramatic play, can express what has happened that could have got them nervous at a previous admission, okay? So again, you always, after surgery procedure, you want that kid to get back where they were, to their normal growth and developmental stages as soon as you can. As in get them up, get them out, get them moving. If they're in the hospital, long-term, school-age children, have the teachers, the students send in cards and send in their homework to get it done. Get them back to that normal growth and development and they won't feel sick, okay? So in all age of children, there's many things we can do, from infants to adolescents. What can we do to help make their situation better? One of the Erickson things, just to say, you have a school age child, they're long term. Yes, they got their schoolwork, but they're done. They need a project to do to occupy them. Well, the one thing you remember is never give them something that they cannot finish complete. Yes, it needs to be a challenge, but don't make it too hard they can't, because that then is the inferiority. So separation anxiety is when they really start knowing the world. 6 months, we know that parents needs to be there with separation anxiety, okay? You can't always, but what it is. So the stages. Now, the first stage is when they parents leave and they cry and cry and cry and they're just standing up in the cribs with the little tops on them so they don't fall out and they're standing up and they're looking and looking for mommy or sitting there looking out the bars trying to see mommy, 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 okay? Usually, it gets to the point where they do fall asleep when they're exhausted because they just keep going. Now, things that we can do, like I was telling you with toddlers, consistent caregivers. Don't let that mom sit there for 2 hours saying goodbye because she feels guilty. I'm going to go see you goodbye. I'll see you tomorrow after you wake up, or I'll see you tomorrow after lunch. Remember, it's never a time, it's always an event that they'll remember. And, always let the kid know that you spoke to mom and mom's going to come. And she said that she's going to come after lunch tomorrow. So they know what to expect. It still doesn't mean they don't protest. Now, despair is all right. They've gone through this exhaustion, crying. Well, now they're sad. This is when they tend to um, go and regress, okay? They are withdrawn, they don't play, sometimes sucking their finger, they don't want to be bothered, okay? What do you do? Well, again, what are those toys, that blanket, the this, is it in there? What's the favorite juice? Get them some apple juice or orange juice or whatever it is. And also let them know, have play, have fun, give them little things to do. I mean, wouldn't you like to give like a preschooler, older than 3, of course, the older ones, maybe some clay to play with or crayons and a paper and having them draw pictures, do fun things on TV, music, whatever, keep them going. Then it's the denial. Children appear that when the mother or father now returns, that they really don't pay attention to them. They're upset. You left me here and now you're not here. Look at my hand. I'm not looking at you, right? That's what they do with it. So they look at everything else and not. So, how do we build that return? Well, a lot of times it's the nurses helping that child. Let's get a toy out. Let's get the parent. Hey, could you get me that toy here? And, bring it over and, try to react the parent. And it does go like that. 2 pain scales that we talk about a lot. Well, the older kids we know is numeric, right? Usually the book says after age 8. So that's from 0 to 10. 0 is no pain, 10 is the worst pain in the world. Tell me, what does it hurt like? Well, that is numeric. These 2 scales are based on that same scales, but they're looked at differently. Now, the FACES scale is for preschoolers. So at age 3, their faces, they can point to the face that tells them how much they hurt. And they do a really good job at it. Now, the FLAC scale is a nonverbal child, could be cerebral palsy, nonverbal, or it could be a young child less than 3 years old. And it measures the face, the legs, activity, crying, consolability. And it really is, I've worked with it for many years. It's a great scale and it's extremely accurate. Remember, pain is the 5th vital sign. That happened in the early 2000s, believe it or not. And remember, pain is what they say it is. You can have, you even see adults sitting there telling you they're 10 out of 10 and they're giggling. Well, that might be the way that they respond to pain, right? So don't look at it like, well, I don't believe them. So the American Academy of Pediatrics says the pain is whatever they say it is. What's the best way when you know they're in pain? Let's say post appendectomy. It's low dose analgesia around the clock, a regular schedule. Don't wait for them to call. Remember, if it gets too much, you can't catch up, right? So, around the clock, low dose is the best. Acetaminophen, mild to moderate pain. It works just fine. Children do very well just on that. Opioids are moderate to severe, postoperative, fractured femurs. Could you imagine that? Because all the muscles hurt. Sickle cell crises, and then cancer pain. Opioids and morphine is used extremely successfully and safely in children. Using numbing stuff for things like sutures, IV catheters, and all different wound debridement. Sometimes it's usually either injected in or it's a local topical type thing. Usually for sutures, wide things, they'll put on the jelly and then they'll inject it with a little bit of lidocaine, and then they have no pain. So they have touch and no pain. We used to use this little tip, and it and it looked like a little needle, but it wasn't. And you put it right where you wanted to put the IV needle in, and you push this button, and there was like a little thing that like popping a soda can, psh, and it put that medicine on top of the skin. And these children didn't feel. They go, no, I didn't feel a thing. Remember, conscious sedation. If the kid has his own airway, that's when they're going to do things, but they're asleep. Flumazenil is the reversal, right? Benzodiazepines, that's the reversal that you use. What do you use for opioids? Narcan. Okay, eyes. Well, most common of everything, I think, is your pink eye or conjunctivitis. It is an infection of the mucous membrane in the eyelids. We know it's spread from child to child to child to child. It's just part of what they do. Hyperopia is when it's farsighted, which actually you can't see near. Why they did it that way, I don't know. Myopia is nearsighted. I can't see far. Now, amblyopia is that eye that sort of doesn't match up, or maybe down, up, crooked, outward, inwards. It's called a lazy eye, and it's a muscle that's weak. How do you treat that lazy eye? Well, it's a muscle that's weak and lazy. Make it work. Cover the good eye, make that bad eye work. Strabismus is when you have two eyes looking forward, and each eye has a hard time looking at an object in their distance. Depth perception is terrible with strabismus. And nystagmus is the eyes just have this jerking up, down, or around type thing. It's just a constant sort of thing. Papilledema, edema of the optic nerve. So let's go to ears. So remember, if you can't hear, your speech is going to be delayed. So if your speech isn't good, or it's delayed, or it's garbled, it's not as clear, always check the ears, okay? Now, types of loss. Congenital. What does congenital mean? That means intrautero, you're born with it. Okay, it could be hereditary or was an intrautero infection. So congenital, it's you were born in the mother and then, born in delivery. Sensorineural is when the nerve cells, the acoustic nerve is damaged and the sound doesn't go from the outer ear into where it needs to go. Then conductive is when the tympanic membrane says, stop, you're not going any further, can't go into the middle ear, so you don't hear. So those are your three types. So you have a child, hearing impaired. What do you need to remember?
Excuse me, Professor.
Well, with any kid. Excuse me?
Can you go over that again?
Okay, the type of hearing loss?
Yeah.
Okay, congenital is what you are born with. That means as a development of a fetus in mom, that's part of congenital, to delivery, that means you're born with it. And it's usually due from maybe you had an uncle who didn't have an ear or had hearing loss. That's hereditary, and it was passed on to the child. Or it could have been an infection intrautero, and that's very common that could be. Sensorineural, remember neural means nerves, right? So this is the sound can't pass across and through the acoustic nerve, okay? Acoustic nerve is the hearing nerve. It's damaged. So there's no connection between the sound and the brain, so you don't hear. And conductive is when the tympanic membrane says, nope, you're not going any further, stop. It can't get through the middle ear, and then you don't hear it. Did that help you? So as a nurse taking care of a hearing impaired child, remember to be down on their level, right? Face to face, that's eye level. Look at them closely. Do not try to yell or overemphasize what you're saying and talk in short sentences. You don't have to yell. If the kid can't hear, the kid can't hear. So, and it's not an uncommon thing that happens. Otitis externa is an infection of the outer ear. It's also called swimmer's ears, right? Swimmer's ears, the outer, and it hurts. We treat that with just a little bit of topical ear drops, and it does help. Otitis media is an acute infection of the middle ear. It's because of those little short eustachian tubes, and the mucus gets shoved back up in there, up into the ear. How do we treat it? Augmentin, right? Usually, and an antibiotic. Remember, the oropharyngeal airway is always with staph. Augmentin, amoxicillin are those that we would treat it with antibiotics. So let's go into seizures. There was a lot on this week's information that we just got over. So what is a seizure? What I call it is simply something in the brain sparks and goes bzzz. What it is. Now, where it is that it goes bzzz in the brain depends on what you're going to see. You're going to see maybe blank stares, right? Which are absent seizures, or you're going to see tonic, clonic twitching, maybe just one little lip or the whole body, or just again, a loss of consciousness. But let's go over some of the names. Grand mal is what you think of when you think of a seizure. That's the arms and the legs, the foaming at the mouth, loss of bladder, both control, and it's followed by a postictal or a period of sleep time, right? They just don't know what happened at that point. Our goal in any seizure is safety. Make sure you walk into a room or wherever you see somebody having a seizure, especially children. They always have toys in their beds and cribs, right? Make sure you clean out the area, turn them on their side, and suction should be in these rooms to make sure you have something, because again, they'll vomit, and we want to make sure that they don't aspirate. So it's safety, turning them on their side, okay? Getting the stuff out of their beds down, side rails up, and suction. Petite mole is like that little absent one, or maybe just a twick on an eyelid. But usually you're talking to them and they're not responding. And that could just be a couple seconds. And usually when it's done, they go, oh, what did you say? And then the person goes, you were gone again. Jacksonian is just one part of the body. Could be the whole arm, the whole leg, the face. And again, that kid will be awake. Myoclonic atonic is jerking motions on awakening. And then it's sudden, you have a sudden collapse. It's 10 to 60 seconds later, they're recovered. Now, status epilepticus is that grand mal that goes on and on and on and on for 30 minutes or more. And usually that's the one that we're going to give the diazepam for, right? And an anti-epileptic medicine. It just goes on again, protecting them from and safety. There you go. I found it. So what causes seizures in a child? Infections, fevers, okay? Remember, febrile seizures, drugs, epilepsy, and hypoglycemia. All of those causes seizures. Again, seizure precautions, I kept saying safety, side rails up. If you have something you could pad the side rails, pillows or something, blankets, put it on there. Make sure suction is there. Also, if the kid goes home, tell the parent they need something to let the public know this kid has seizures. There will be a time where they're not going to be around somebody who knows them. It happens, maybe school or there's a different teacher, medical bracelet, something. And then make sure that they know that compliance with medications and follow-ups are important. And the one thing I don't think we think of is a kid who has seizures, you wouldn't let them go swimming in the middle of the pool alone with somebody who cannot swim with them because they could have a seizure and, drown. So make sure that they are protected. Okay? And the treatment is multiple. And remember, we try to start with a little and add on for the least amount of side effects. So, the inflammation of the covering of the
Professor,
brain. Yes.
I'm sorry. Can you go over the treatment again? You were breaking down when you were talking about it.
The treatment and the medication depends on, of course, the seizure. A febrile seizure are nothing, but remember those epileptic ones that we know continue. We start with one, we start with lower doses and work up, and we'll add more medications to it. We don't like to just give a lot of it. So the least amount of drugs because we want the least amount of side effects. So the inflammation of the covering of the brain and spinal cord is Haemophilus influenza. And it's a common one. And influenza, that's your viral one, believe it or not. Then, of course, we have a bacterial, which we've already discussed the strep, right? Group B strep. And it's all about, that inflammation and the pain of it. These children with fevers, headache, their necks are just stiff, and you could tell this headaches, we know this kid doesn't feel well. Remember when you have a kid who is a possible meningitis, they should be placed on droplet isolation. Why droplet? Because it's airborne. Droplet, what does it mean? They need to have, you need to wear a mask. They need to be placed in a reverse airflow room. And if it's a bacterial, you need to be on that antibiotic for 24 hours and then they can be taken off. Then they're considered safe, okay? So some of the neuro checks that you'll be checking, remember there's an inflammation of the brain. So we're going to be concerned about the neuro status. So weakness of limb, meningitis, and that inflammation of it, of the brain, because of the headache and the photophobia a lot of the time, quiet, darkened atmosphere environment for them. Always record vital signs. And especially when you're talking brain and fluid balance, intake and output's very important. You don't want them to be fluid overload, puts more pressure in the brain. So fractures, sprains, and strains. Well, green stick is incomplete. One side's broken, the other's bent. Simple. Compound, fracture that sticks out of the skin. Big thing with that one is the possibility of osteomyelitis because that bone sticking out, it's getting infected. That's going to need an antibiotic. Simple fractures, mostly what kids get. It's broken, the skin's fine. It could be oblique, spiral, different types of fractures, but it's broken, the skin is good. Now, oblique just says it's crossways, it's an angle. Now, the one that we need to be really concerned about is what we call a spiral fracture. It's sort of a cracked this way, and it's they grab the kid's arm and twist it and pull it, and it's very common in child abuse, okay? Now, there's a lot of things that children that could trigger child abuse. And what are those things? Well, we know that it could be drug abuse, could be poverty, could be financial difficulty, homelessness, they were abused as a child. It's something that, you should take a look at the last PowerPoint from last week that we did. Those factors are important to understand and understanding spiral fractures. And what is your job? Again, to report it, making sure I'll always keep the kids safe. So a sprain, can't tell you how many sprains I had in my life. The ligament's torn away and it ruptures blood vessels and muscles and nerves and it swells and it's very painful. Again, it's going to be rice, right? Raise, ice, contain, and elevate. Strain is when you're doing something repeatedly over and over again. Let's say riding a bike. It could be the front of the shins, right? And then a contusion is you bump into something, fall down, and then it breaks blood vessels and you see those big bruises, right? The ecchymotic areas. Those are pictures of those sort of fractures that I just discussed to give you the visual. Now, some of the bone issues that can occur. Scoliosis is where there's an S-shaped curvature of the spine, and if you saw them visually, one arm looks more they're bent forward. And how do we treat that? Well, you're not going to put lotions or creams underneath on the body. What they need to do is put on a t-shirt, wear that brace, sometimes called a Milwaukee brace, 23 hours a day. And then there's physical therapy. And those bones can straighten up good. Ewing sarcoma is a type of sarcoma that's in the long bones. It's a cancer, radiation and chemo we give. Leg calf perth, very, very confusing diagnosis, but this is a really important type of condition. This kid all of a sudden starts limping, and the end of the femur bone gets an aseptic sort of infection, causing pain. And then the head of that bone becomes malformed. A lot of times it leads into hip replacements in the future, but leg calf perth, an aseptic infection. It means no infection, it's aseptic, but the bone starts to dissipate. And then the head of the femur gets, developed differently. Now, JIA is an autoimmune disease. We have the one that attacks the joints in the body, and that's JIA. And we know that lupus attacks organs. This is the body going into those joints and creating inflammation. It can be in connective tissues and into the viscera, okay? Now, you can have one joint or you can have a whole bunch of joints. So oliguria arthritis affects four or fewer, all right? There's different things, but that's the one you want to know. Osteosarcoma is, again, another primary malignant tumor of the long bones. Again, I said it a lot of times in the femur. Many times these children are placed on traction, and we're going to get into that next. Duchenne muscular dystrophy is a boy, ages 2 to 7, with progressive muscle degeneration. You will see they are cognitively delayed. So they will walk, and then all of a sudden you'll see these big, thickened, hypertrophic calf muscles, they call it. But they're like these big calves on these children. All of a sudden they'll start waddling and falling because of the progressive muscle weakness. So that's Duchenne's. Torticollis is a neck crick, right? It's the sternocleidomastoid muscle, and a lot of times that happens from birth, the way that they come out. Physical therapy will take care of it. So I just mentioned with the fractured femur, what we do is we put them on traction. Now, traction, this one is skin. There's no bones, there's no pins. You put this boot on and wrap it up, and it pulls the leg. And it makes sure that the legs are pulled and the bones come out and sit there. and it will wait until they can do surgery. All right. And there's a weight on the end and it pulls it. So it holds the body stable because you want to keep that bone straight. All right. So we never take off that traction and we keep it straight until they go to surgery. So what is traction used for? Well, we want to keep those bones on the end to end so we have one leg not shorter or longer than the other. It also reduces and immobilizes it because those bones are full of little tiny sharp areas that get into nerves and the muscles, and it really, really hurts. So it decreases them, and also it prevents those deformities and it helps all those muscle spasms. Now, what is your job as a nurse on Buck's traction? Well, whenever you have something broken, anything in a leg or any injury in a leg, you should always be concerned about neurovascular signs. All right. So you have a child with fractured femur on Buck's traction. You are going to be checking their pulses, their dorsalis pedis and the posterior tibial, frequently. What if you all of a sudden don't feel a pulse? Well, you're not getting blood flow down to the foot. You're going to call the doctor right away. Call the healthcare provider, all right? So, another thing you might see is diminished or even paler, or the colors getting white or cyanotic. Again, always check for circulation being compromised. You want to keep that foot and leg pink and blood flowing. Now there is other traction, cervical tractions. We have Crutchfield traction. These are pins. And again, it's putting bones in straight and holding them and giving them pressure so there's no compression there. Cerebral palsy. Cerebral palsy is usually caused during the birthing process, and it has a lot to do with oxygen deprivation. If you have a difficult birth, I'll give you an example where a baby was coming out, couldn't get out, they had to quick do a C-section, push.
You pause, we can't hear you. We can't hear you, Professor Paulette.
Her internet, I think her internet first.
Oh, there you are. When did I lose you? When did I lose you? Which side?
You were saying if you had to hurry up and do an emergency C-section and the baby couldn't get out.
We were talking about cerebral palsy, wasn't we?
Okay, here we are. Yep, right here. That was crazy. Thanks for waiting, guys. So when the baby can't get out, you do a C-section. A lot of times you're going to see that hypoxic anoxic episode, okay? So you're going to see them with movement. It affects the movement and the muscle tone and the posture of the child. These are ones that you really have to make sure that if they're sitting in a wheelchair, you use their harnesses to keep them strapped in, because sometimes they arch or they just don't sit the way that they, quote, should. What we know about this is we'll find it when we're doing our developmental testing. Are they growing the way they should as an infant, right? Are they lifting their head up and turning over? And we're going to see, that their reflexes and whatnot aren't where they should be. As they get older, you're going to see that floppiness, rigidity of limbs, trunk, that posture different, involuntary movements, unsteady, or they can't move, or any combination of all these things. So what are some key terms you need to know? Well, spastic cerebral palsy is when they have these stiff, awkward, and they're so excited to see you, they get so tense and they put their hands out and they're just stiff, like all their muscles tighten. Athetosis is an involuntary, purposeless movement that can interfere with a child's normal motion, which means I'm, trying to get something and my hands go wrong and I can't get there. So it's what is my hand doing there? It's like involuntary and it doesn't get the child anything. Opisthomatosis is an involuntary arching of the back. So their back arches, this is the muscle that will spasm. So this is all sort of spasticities that you see in children, okay? So spasticity could be spastic, it could be athetosis, or opisthofonatosis. It's different things, hands, movements, back, or just different areas. So child abuse, I was talking about early triggers. So social, poverty, unemployment, the function of the family, they need more care, they're temperamental. How about that hyperactive child, autistic child, foster child? And then we know that parental stress could be just due to, they were abused or they're overworked or they don't feel good about themselves. They're undereducated, can't get good jobs, and it could be substance abuse. And some of the triggers for child abuse is a need for discipline, it's a conflict, it could be financial, and again, substance abuse is a big thing. There's different sorts of abuse. We have emotional, we have sexual, we have physical neglect and abuse. Emotional is when, you're fat, stupid, and ugly. That's emotional. That would really be abusive to me, right? Sexual abuse could be by anyone in the family or neighbors, next door neighbor, anyone. Um, and again, doing things to a child that just shouldn't be done. Physical neglect, they don't have a house, they don't have food, they don't have clothing, they have no basic needs, Maslow's, right? Basic needs. And then, of course, physical abuse is when you could see bruises and, different things. I've seen cigarettes, cigars put out. I've seen food withheld, um, too many things. So it's the end of it today. Again, those are all of the type of dosage calc. I'll be sending these out today for your other professors so that you will get them. I know you're going to do good. Everything you need, I've talked about today because I went over this again, just this morning to make sure that you all have all the information you need. And I just hope I presented it in a manner that helps you. Thank you, guys. You have a great Mother's Day.
Thank
you.
you.
You as well.
Appreciate you. Have a good evening.
Take care and be safe.
Bye-bye, guys.
Bye.
You as well.
Happy
Thank
Mother's
you.
Day.